Good day. I am Noluxabiso Mangwana from South Africa. I am going to present my project titled The Impact of Treatment Practices on Mortality Among Patients with Invasive E. coli Infections in Public Sector Hospitals in South Africa. E. coli is a gram-negative bacterium that forms part of the normal gut microbiota in humans as well as in animals. And when it enters the bloodstream, it disseminates into distant organs, leading to sepsis as well as organ failure. E. coli bacteremia poses a significant burden on healthcare systems in South Africa, with over 9,000 cases reported in 2023 alone. This burden is further compounded by the frequent antimicrobial shortages and the lack of standardized national guidelines, which may result into inconsistencies as well as delayed administration of antimicrobial treatment. Additionally, rising antimicrobial resistance, delayed diagnosis, and inappropriate therapy increases the risk of poor clinical outcomes, including mortality. Therefore, the aim of this study is to describe and evaluate the impact of antimicrobial treatment therapy on mortality risk among patients with E. coli bacteremia admitted in public sector hospitals in South Africa during that period. Study is guided by these objectives. Objective 1 is to describe demographic and clinical characteristics of patients with E. coli bacteremia. Objective 2, to describe antimicrobial treatment patterns. And objective 3 is to determine the proportion of patients receiving inappropriate therapy and determine their 14-day and 30-day mortality risk compared to those who receive appropriate therapy. We conducted a retrospective cohort study, and the study was conducted using the GERMS SA Enhanced Surveillance site. The sites are denoted by the pins in the map, and we looked at 16 hospitals. And these 16 hospitals include tertiary as well as academic hospitals. And a case was defined as a patient of any age with E. coli isolated from blood culture at the GERMS Sentinel surveillance site between April and September 2023. And again, a patient with a subsequent positive culture 21 days following the previous blood culture were considered to have a recurrent episode and were included. We excluded patients with co-infections and those who were not administered any antibiotics. We then defined appropriate treatment therapy by empiric therapy that is active against gram-negative bacteria initiated before or within 48 hours of blood culture collection, and targeted therapy with an antimicrobial appropriate for E. coli bacteremia to which an isolate is susceptible to. And inappropriate therapy was defined as an empiric therapy initiated more than 48 hours after specimen collection, or empiric therapy with an antimicrobial not recommended for E. coli bacteremia, or targeted therapy with an antimicrobial to which an isolate is not susceptible to. After applying the case definition, we had 663 E. coli bloodstream infections that were identified. We went then to exclude a further 87. After that, a total of 576 patients with E. coli bloodstream infections were included in the study, with 355 patients receiving appropriate treatment and 221 receiving inappropriate treatment. Overall, most patients receiving appropriate antimicrobial treatment were 62%, while 38% received inappropriate treatment. And by age group, adults accounted for majority of the population, with 51% of them being adults, and females constituted for a larger proportion in this cohort. Now, when we focus on the provinces that these patients were treated in, Gauteng accounted for the largest share of patients in this cohort, reflecting either a higher burden or reporting from this province. In contrast, the Western Cape had the lowest proportion of patients receiving inappropriate treatment at 15% compared to the other provinces. This suggests relatively better adherence to appropriate treatment practices in this particular province. And when we're looking at the clinical characteristics, bacteremia with no focus was the most common E. coli-related diagnosis. And among these patients, 59% received appropriate treatment therapy with no significant differences between the treatment groups. HIV status was available for 499 patients, and of these, 24% were living with HIV. And among the HIV positive patients, 46% received inappropriate treatment. Then looking at the 30-day mortality, 34% of the patients died within 30 days. And among those who died, 44% of the patients received inappropriate treatment therapy. And now when we look at the antimicrobial treatment patterns, amoxicillin, clavulanic acid, as well as your ceftriaxone were the widely prescribed empiric antimicrobial treatment. Whereas the broad spectrum antimicrobials such as your amikacin, ceftriaxone, and carbapenems were commonly prescribed among patients receiving appropriate antimicrobial treatment. In contrast, amoxicillin clavulanic acid was more frequently prescribed among patients who received inappropriate antimicrobial treatment. And when we're looking at the antimicrobial susceptibility testing that was conducted, we noted low antimicrobial resistance activity to amikacin as well as your carbapenems, while the frequently prescribed empiric antimicrobials such as your amoxicillin, clavulanic acid, as well as your ceftriaxone had a comparatively moderate resistance at 24% and 31% respectively. Then we looked at the risk of being administered inappropriate treatment. We conducted a multivariate logistic analysis. In the analysis, we noted that patients who were treated in the Western Cape province and those with renal disease were significantly associated with lower odds of receiving inappropriate treatment. We then used this multivariate logistic regression to create propensity scores or weights to be able to reduce the biases between the two treatment groups. Then a weighted cost proportional hazard model with robust standard errors was used to assess the association between treatment appropriateness as well as time to death. Patients who received inappropriate treatment had 1.8 times higher hazard of death within 14 days compared to those who received appropriate treatment. And for the 30-day mortality, patients who received inappropriate treatment had a 1.56 higher hazard of death compared to those who received appropriate treatment. And the Kaplan-Meier curves show a clear, consistent separation between the two groups over the follow-up period. To summarize the study, 38% of patients received inappropriate antimicrobial treatment. This could have been due to poor selection of empiric treatment by clinicians. For factors associated with receiving inappropriate treatment, patients treated in the Western Cape and those with a renal disease had lower odds of receiving inappropriate treatment. And looking at the antimicrobial treatment patterns, the first-line antimicrobial treatment therapy, your amoxicillin, as well as your ceftriaxone, showed that there is antimicrobial resistance. Their patterns are on the rise. Overall, inappropriate treatment was associated with a significantly increased risk of mortality in both short-term and medium-term following diagnosis. Therefore, we conclude inappropriate antimicrobial treatment was an independent predictor of mortality in patients with E. coli bloodstream infections, highlighting the need for timely, effective therapy and stronger antimicrobial stewardship. We then recommend that the South African National Department of Health to update the standard treatment guidelines for bloodstream infections using local resistance data and medicines available in the public sector. Also, they should integrate treatment appropriateness indicators into surveillance systems, and also to conduct mixed method study to understand the drivers of empiric prescribing in public sector hospitals. I would like to acknowledge the following institutions and people, and thank you.